like today than sit in a lecture. So let's, hopefully we'll learn a lot today and answer some questions for you guys. I used to be able to do this off the cuff, but as I age, I now have to write all this down. I want to thank the Backcountry Horsemen, Brenda and Lou are here. We're kind of help sponsor the Backcountry Horsemen, and so any donations you guys can do will help their club out. Sign up for the club, find out a little bit more about what they do. I want to introduce some new staff that we have that some of you may or may not have seen. Dr. Defoe is from Ireland. She's in the back here. That you may have seen her out on calls already with us. She's been with us since May. And then Erin Green, where's Erin at? Erin's in the back as well. She's a new assistant that we've hired to be on the road with us to help us. So some new faces you might see when you come out. There are some drinks and cookies and snacks. The bathrooms are in the back. For those of you who haven't been here, feel free to get up and refresh yourself as you need to. I also wanted to talk a little bit, before we get into the speakers, some new and exciting things we have coming up in our practice and some things that we're working for. This is a great forum for us to kind of get the word out to you guys what we're doing new. Who here has filled out the survey for us? Has anybody here did that survey about a while ago? So from that information that we got, we are starting to put it to use. We're trying our best to find out what you guys want, what the horse community needs, and to service that as best as we can. So a few things that are coming along. Dr. Cruz is now board certified not only in surgery, but in sports medicine and rehabilitation, which was a pretty rigorous process for him, but he made it through. So we're happy to have him as a part of that in the Northwest. So along with that, we're going to be devising some sports medicine programs for anybody that might be interested. And that's going to cover things like movement evaluation, studies of the feet, nutrition, consultation, and fitness testing in horses. So that's going to be coming up new in the future. Hopefully by next spring, we'll have some of these programs outlined very well. I myself am taking a chiropractic course in veterinary spinal manipulation. This is really a course in functional neurology, not just a chiropractic course where they go out and they kind of show you how to do some things and manipulate some spines. It's all scientifically based, research-based in how the body works from a neurologic standpoint and how we can help some of these horses. So we're also going to be developing some integrative medicine programs, which will be a way to look at your horse from a chiropractic and acupuncture and a musculoskeletal standpoint. So all in one exam, you're going to have basically 3 different ways to look at that, and along with that chiropractic method will be from a neurologic standpoint as well. I'm not saying that your horse has neurologic disease, but how we can help him start to function better. Also that's coming along is we're going to have a patient referral program, and we'll have some more details out on that coming up probably this winter. Over the next few months, we're going to devise this, so keep us on your email list. And what this is that it's come out of the survey a little bit, but how many here are on some type of rewards program, whether it's your Visa card, whether it's a point system, whether it's something like that. So we're going to try to implement something like that for you guys, because you guys are our best source of referrals to other people. It's your support and your help that helps us do what we do for these horses. So we figure that you guys need to be rewarded for that. And we've always struggled in the past on how to do that, but now we've kind of started to work with some marketing places and how they do their programs. We're going to try to offer that to you guys as well. So keep your eyes open for that. That's going to be coming up in the future as well. Something else that's new that's coming down the pipe is, one thing we're really proud of here is our internship program. And at Paton and Martin, we're really steeped in education and doing things on a research and scientific basis. But part of that education is educating veterinarians coming up in our internship program and externs that we've had. So I know some of you guys notice that we come out sometimes to your farm with extra veterinarians at the hospital. They serve a huge function in helping care for the patients in there, provide an extra level of expertise. And in the coming future, you'll probably see 3 instead of 2 new bodies with us. And that's because we'll be sharing that 3rd intern, or all interns will be rotating around, but with Dr. Samper, who's in the back. We're helping amalgamate that internship program to where those people get a very well-rounded view of the reproductive world, as well as the hospital setting, as well as the ambulatory setting. So if you see some faces that look like they're mixed around with practices, that's the reason why. So we're really excited about that part coming up. Our Facebook is going great. I hope you guys are happy with it. If there's any suggestions you have, by all means, pull one of us aside, send us a message, email us, let us know. We're happy to try to get anything on there that you guys are interested in looking at. Our website's going to be getting revamped again as well this winter. It's been a long time since it's happened, but we're going to start to try to streamline that a little bit better too. So I'm going to now introduce Dr. Ford. Since I've gotten through my part. So Dr. Marnie Ford is going to be speaking tonight on the equine eye. We're very fortunate to have her in the Fraser Valley here and working in conjunction with our practice seeing horse patients. She's originally from Vancouver. She graduated from the Ontario Veterinary College back in 2000. She did a residency in Minnesota, then went to Missouri, which is where I'm from actually, and did her residency there. She then came and was working with Dr. Keller at West Coast Eye Specialist and is now branched out on her own as a consulting ophthalmologist at Pacific Animal Eye Specialty Services. So Dr. Ford can see patients at our hospital, at our clinic for anything that's getting tricky or any problems that you might have that you would like an extra set of eyes and a specialist to take a look at these things. So let's get started. Dr. Ford.
It's not going. No going.
I don't know.
There you go. That was good. Got it.
Awesome.
Look forward to it.
Thank you. That's awesome. Thanks.
Yep.
Thanks, Juan.
Okay. Sorry, that's actually good because now I'm not going to keep walking away from very often. During this, there's going to be some kind of yucky pictures, and I know everybody has seen gross things before, but just I have a star in the corner here. If there's going to be the next slide is gross, so if you're squeamish, not feeling well, maybe you can have a look. Someone more happy. If you've got questions, please ask them at the time. I mean, ask them afterwards if you want, but it's always good at the time because I'm sure other people are wondering the same thing that you are, and hopefully I can help you. Okay, so I thought we would just start out with some of the basics, and that means the anatomy of the eye. You've all got horses, you all know what they look like, but there's some interesting things that happen inside of eyes that, you know, it's just kind of cool. It makes them a little different than people. Then I'm going to go on very briefly and talk about the examination and what I would do if I was coming out to look at your horse. Some of the common abnormalities that you'll see, there's really 8 major common abnormalities, and then we'll talk a little bit about traumas. And when would be a good thing, when would be a good time to call your vet to come and have a look or find out if there's something going on. Sometimes it's just knowing what the guidelines are to call. You know, this is important and not important. Okay, so as far as the basics go, eyeballs for horses are enormous. They are almost 5 centimeters high, 5 centimeters wide, 5 centimeters deep. I mean, that is a big structure. And I brought a syringe because I thought it would be helpful to just see it. Because when I was researching this, it was kind of like, wow, I didn't realize they were so big. But up to here where my finger is, that's how much fluid is in one eyeball. Between 45 and 50 mils, that is huge. And I actually didn't think about it ever. It's one of those numbers you learn for your boards, but you don't really get it in your brain until you pull it out and you go, holy crow, I didn't know they held that much fluid. So I just thought it would be nice to see it. The eyeball itself structurally is made up the same. It has the same structure as a human eye, dog eye, cat eye, pig eye, bird. They're all the same. So the outer coat is the sclera, which is the white solid part of the eye that you see, and then that actually turns into the clear part of the cornea, or the eye called the cornea. So it's the same tissue, it's just that the collagen fibers are made differently. They're all haphazard to make it solid, and they're perfectly oriented, almost like glass, so that the light goes through, and that's what makes up the cornea here. Inside that, you've got a big fluid structure, or fluid space, which is filled with aqueous fluid. It's kind of like water. There's a big lens in there, which again is just protein fibers. And then behind that is another big protein-filled fluid space called vitreous. And vitreous, unlike aqueous, is very much like, I don't know, thin mucus or thin jelly, and you can't mix the two together. If the vitreous gets into the aqueous, you'll notice it as little veils of a fluidy, fibrin type material. So it's supposed to be separated. And then, of course, in front of the lens is where your iris fits, the colored part of the eye. And then the lids. Horses, like dogs and cats, and birds are a little odd, but all these other creatures, anything but us has 3 eyelids, so they've got the 3rd eyelid that comes up over top of the eye, and that's there to protect the eye when they're out racing around in the woods, from walking in, to keep them from hurting their corneas, and it's a good thing to have in place. And sometimes if they're not feeling well, or sometimes for other reasons too, that 3rd eyelid will be prolapsed or elevated, and you look at them and you go, wow, what is that funny thing? But it's actually normal, it's just it shouldn't always be hanging up in front of the cornea, obviously. Okay. So this is just the front view. Again, this is the part that you would normally see. There's the 3rd eyelid there. That part rises all the way up. It can actually cover the entire cornea, and that's a good thing. The white scleral coat, clear cornea covering the front. The iris, which is typically pigmented in most horses. The pupillary space, obviously, it's oblong, and that's just simply a function of how the muscle fibers are laid within the iris. And then you've got this little funny structure called the granular reticle, which is just an extension of the iris. And a lot of animals will have those. Okay, this is always something interesting with the horses. They actually have a tremendous visual field. Their total visual field per one eye is over 200 degrees. So that's pretty huge. They can actually see almost to the back and almost to the side with the one eyeball. So it's pretty phenomenal. They have a really small binocular area, only about 65% forward. They have a big blind spot behind their backside and a little bit in the front. But each eyeball, just on its own, sees 146 degrees, just from one side, to not including the other side over here. So that's actually really big, and that makes a lot of sense, because this is actually a prey animal, as you know, and God knows they get killed. The funny thing about these guys, when you're looking, because their binocular vision is so poor, one thing that they do that we do, but we don't do it as well, is something called motion parallax. You might have heard of this before, but have you ever watched your guy out in the field and he's sort of going like this? He's trying to figure out where something sits. And so if you move your own eye, move your own head back and forth, if you're looking at those windows, for example, the pillars between the windows are actually moving faster than the structure in the background. And that's how you know something's closer or farther away. And so horses will do that a lot, because their eyes are pretty much on the sides of their heads. And so they're able to tell whether or not something is closer or further away just by doing what's called motion parallax. And it's kind of neat. So some people will say, well, if he's lost an eye, he's got no binocular vision. Well, that's true, but they also have the motion parallax that they use a lot more for their daily getting around than we would use, for example. We rely on our binocular vision. And yet we actually do use that. We're just not aware, because we've sometimes sat there and gone, like this, right? That's what we're kind of doing too. We're sussing out where the distance is on something. A horse's vision is 20/80, meaning that what we see at 33 feet, they can only see at 20. Dogs are only 20/80. That's pretty bad. That's legally blind. So it's true. So horses are actually pretty good. They see at about 1/6 or 60.6 of what we would see, whereas compared to a dog, they see 1.5 times better than your dog does, and they see 3 times better than your cat. Cats are ridiculous. Like, I don't know how they even get around. That's true. Anyways, and they do see red and they do see blue, just so you know. This is unlike a dog that sees yellow and blue. And we don't know what cats see, because it's really hard to tell. But the horses are red and blue, so if you're looking for balls or something for him to play with, or buckets or whatever, those would be good choices if you actually wanted to see them. Okay, so when I come out and we're doing the exam for the eyes, because they can sometimes be a little hard to look at, because some of them are a bit, they dance around a little, they're a little excited, and they're not telling you what's going on, obviously. So we're obviously looking at them awake as much as we can, because we want to get neurologic function, we want to make sure the pupils are working well, their manus responses are working well. We want to actually make sure we're seeing what we're supposed to be seeing. So we try to get them awake, and if we need to use a twitch, fine, topical anesthetics is fine. And sometimes we'll do local lid blocks, because you know as well as I do how much, if you've ever tried to put medication in a horse's eye, how much they scrunch them down. Like, my God, I think all the muscle powers in their eyelids. So we actually have to block them with a local anesthetic, just so we can actually get them open. And then if all of that's working, we get what we need to do, but the guy is just jumping around and going off, then we do them sedated as well. And that's okay. So local lid blocks if we need to. The first thing we're looking about here, as I mentioned, when they're awake, it's important to do this when they're awake, because we want to know neurology. We want to know how their pupils function, because that will change when they're sedated. We want to know how well their eyelids work, how well their third eyelids function, and also if we feel that they're visual. We do that through a manus response. So if it looks like we're going to try and poke them in the eye, they're supposed to blink and try to get away with it. Young foals won't do that. They haven't learned that response yet. Young dogs won't do that. If anybody has a puppy and they're less than 2 to 3 months old, you try to poke them in the eye, they're going to just sit there and look. Because it's true. They're just learned. It's not something. I guess somebody's poked them and then they learn the response. But it's usually around that age. Then we're doing what's called a slit lamp exam. This is a slit lamp here, and it's, you know the one when you go to the optometrist and they put your chin on and you have to stand there? That's a slit lamp, but we obviously can't. So we have a little handheld, and it's like gold. And what we're looking at specifically is we make the beam really narrow, and in that you can tell depth within the eye as to what's going on. Because it's like looking at smoke through a projector beam. You know, in the old days when you could smoke in the theaters. And you can tell at what depth, right, something is happening inside of the eye. So that's really a good tool for us to be able to use. And this is what it would look like from the cornea and then into the eye, and then you can see the iris. And then behind that there's actually a lens, but it's not showing up. So you can get different different lines where it's actually hitting the structure, and it should be clear all in between there. If it's not, there are problems going on. We also do something called, so that's looking at cornea, anterior chamber, and lens. And then we look at the back of the eye, that's called the fundus. And this is essentially what it would look like through the lens that we're holding. We just hand hold the lens. We don't use anything up close, those are ridiculous. We just use a handheld lens, and you can get the whole look at the back of the eye, which is really neat. And from that, you can see the optic nerve and some vessels and this gigantic thing called the tapetum. This is actually a horse here. This is a cat. They don't have that big, beautiful mirror called the tapetum. They just have this gigantic optic nerve and these little brush blood vessels coming around. But that's what's normal for a horse, and so that's what we're trying to look at. And then we obviously want to look at the orbit as well. Palpating around the eyes. Are they symmetrical? Do the eyes come out of the head in the same amount that the other eye does? Are the eyelids open in the same way? So there's a whole lot that goes into the exam, and being awake for most of it is what's really important. Okay, so common abnormalities. Just want to make sure I didn't skip anything here. No. So ulcers are number one. I think that's probably what 60–70% of my calls is ulcers, and that includes small animals as well. They get into trouble. And then uveitis means inflammation. So inflammation-itis, anything is inflammation and of the uveal tract, and that means anything regarding the blood supply within the eye. So inflammation of the uveal tract. There's conjunctivitis, so inflammation of the conjunctiva. Cataracts, you're probably all familiar with cataracts. Glaucoma, too much intraocular pressure. Sarcoids, I don't know how big are sarcoids here? I don't see them very much here. I used to see them all the time in the States. Do you see sarcoids? Yeah. You see people traditional.
Yeah.
That's my experience too. They probably still do that way. Squamous cell carcinoma and some miscellaneous things. Iris cysts, heterochromia iridis, so different colored irises, different colored eyes. And then we're going to touch on trauma, just so that you're aware, because you're all going to have it's going to happen. And so we just important to know how important this is, and what do you do about it, right? Because not everything requires, a visit. So a lot of things you can deal with on your own, which is really nice. Okay, so ulcers. An ulcer is when you have a break in the surface of your cornea. And your cornea is the most incredibly innervated part of your body. It's actually the most innervated part of your whole body per millimeter, not total. So per millimeter of corneal tissue, there's more nerve endings. And so that's why when you have a little break in it, it's like, holy cow. And that's why these guys squint a lot, they tear a lot, they have a lot of redness around their eyes. They're often rubbing, and that actually exacerbates everything. You come into the barn in the morning and there's this big swollen eye, it's just, And then you get focal edema. So this would be an example of focal edema. That's fluid retention within the cornea. See, it's clear here, but it's focal here. And that's another sign of an ulcer as opposed to something going on within the eye. So this guy's squinting and tearing, another squinting, tearing, red, squinting, tearing. There's so many squinting tearings because it's hard to photograph an ulcer. Although I have some pictures of them. The cornea itself is made up of really 5 layers, but 4, and then I'm only going to really discuss 3 because one of them you can't even see. The outer layer is fairly tough. It's called epithelium. It's kind of like the outer layer of your skin, and it's multiple. It's usually 8 to 12 cell layers thick. It is considered a water barrier, so if you put, what we use to determine an ulcer is you put fluorescein stain on it. Fluorescein dissolves in water, and it only holds where tissue wants to retain water. Well, epithelium that's intact won't retain that fluid, so that's why when you put fluorescein dye on a cornea, it doesn't hold. There's no stain there, except where there's a defect, and then it will hold, and that's how we know exactly how big an ulcer is. This is called stroma, which is the body of the cornea. And it's mostly collagen, and it's highly organized, which is why you see right through it, as opposed to seeing like skin, which is all haphazard, and the light just bounces off it, so you see this as an opaque structure. It doesn't have as many nerves, so the nerves are really up at the top third of the cornea, and it is responsible for about 90% of the corneal thickness. One of the other reasons why it's clear is because it's incredibly dehydrated. So when you get fluid in, because you've got this now break in the water barrier layer called the epithelium, water pours in there, and that's why you end up with focal edema, because the edema comes in and separates little fibers, and then it mismatches all how your light reflects down, and then you see it as a gray structure. And then the very, very bottom layer in red, because it's very scary, dangerous when you get down to an ulcer this deep, that's called descemes. It's named after some fellow in France, I think. Anyways, it's only 1 cell layer thick, so that is ridiculous. You could blow through this. And so when horses come to see you and they've got this incredibly deep and clear ulcer, Those are about to rupture, and they're really scary. So those are often surgical ulcers. They are very thin. So an ulcer at its center is only 1 millimeter to 1.5 millimeters thick. This is the whole structure. And on the periphery, it's only 0.8 millimeters. So if they get an ulcer, usually you got to kind of get on board with these things, because if it gets infected and it goes deeper and deeper and deeper, you can potentially lose an eye. As far as ulcer size go, I don't care less how big an ulcer is. I really don't. If it's the whole cornea that's this superficial, so what? It'll all heal quickly. You can lose an eye though from 1 millimeter square full thickness ulcer. So it's all about depth. It's not about size. So sometimes if you see the stain on the eye, if your vet has put the stain on, you go, holy, that's big. I wouldn't take that as your concern. Find out how deep it is. So this is looking at the cross-section. Remember, epithelium, stroma, descemes. A superficial ulcer would still be in the epithelium. Superficial stromal just hits inside that stromal layer. Deep stromal, obviously. And desmetaseals are way down at the bottom, and these are the scary ones. So up until some deep stromal ulcers, you can treat them with medication topically. It's just the degree of aggression that you want to use. So sometimes it's 2 or 3 drops a day, and other times you're every hour with these things. And if they're really intense with medication, then sometimes you have to be putting in a lavage system under the eyelids so that they're always getting medicated. Otherwise, these poor guys, they'll squint their eyelids, they'll see you coming, and you're never going to get it open. So this way they can squint all they want, but they're still getting their meds. And in some deep stromals, and every desmetacel is going to be treated surgically. And I'll explain how that works. So here's some pictures. So that would be superficial ulcer, and oopsie. Shoot. How did I do that? Sorry. Perfect. Thank you. Okay, I'll try not to do that again. So that would be a superficial ulcer, and you can see how the green is it looks almost just like a little skiff of green. So that doesn't look too bad.
And has that,
They're actually,
Hey, what?
they're actually green?
Oh, yeah. And in fact, we use a blue light, and it makes it fluoresce. It's cool. So yeah, they look, you can't miss an ulcer when it's on a cornea. It's pretty awesome. Okay.
But that's after they've been stained, right?
yeah, that's the stain.
Yeah, that's after it's been stained. Is that
yeah.
color?
Oh, yeah, that's, yeah.
Thank you.
Yeah.
I'm just not sure.
I've been looking for green blobs. So.
Yeah, I know. It's the dye is called fluorescein. That's what Dr. Ford was making reference to. So because it fluoresces. So.
Fluorescein stain, yeah, and it's very safe. They actually use fluorescein to inject into your brain if they're doing dye studies, so it's something that you don't have to worry about if it gets inside of the eyeball. This would be a superficial stromal, and you can actually see how it looks. This looks very solid and superficial. This looks actually like a crater. There's an actual structure to it. Deep stromals would look, now this is an example of melting, but this would be considered a deep stromal because in the very center you're starting to get a hint of clarity. That's always a bad sign. And then this is a desmetacel. So this is actually almost full thickness, and this clear area here, which won't retain any fluorescein stain, is actually bulged forward. So there's, because of the pressure that, remember the 50 mils, it's sort of pushing forward, so it's pushing that very thin membrane of descemes up forward towards you, and those are really scary. So those are the ones we want to do surgery on. Melting ulcers. This is alluding back to that other picture. Corneas, when they're infected with certain bacteria, so Pseudomonas is one, beta hemolytic, streps are others, and by the way, these are part of their normal flora. So they're opportunistic. And the problem with those is that they will actually chew up a cornea they can chew it up in about 12 hours. So I've seen them go from no ulcer to full thickness perforation in 12 hours. You can almost see it happen, and it melts off like candle wax. It's really gross. So it looks a little like that. And then it would progress to that. And this is a bit of a later game, unfortunately. So this poor guy didn't quite make it with his eye. The reason why those particular bacteria are bad is because they contain proteinases or stromolysins. And the collagen fibers is a form of the stroma, and the lysins are chewing it up. So these are bacteria that actually actively chew the corneal stroma tissue. And so what we have to do for that is to try and put medications on that reverse that process, or at least halt it so that the eye can have a chance to heal these things up. This eye, like for example, this one here is not necessarily a game over thing. Sometimes we just treat those really aggressively with medication. You can actually get them to reverse. This guy obviously no. This guy I wouldn't do medically at all. He'd be a surgical. Okay, so medical therapy would include things like topical antibiotics. Antibiotics, by the way, whether they're topical or systemic, are not healing the ulcer. Nothing heals the ulcer but the horse. What you're doing is you're providing the environment that will allow it to heal. So you're allowing it to not continue to be infected and hopefully killing the bacteria that are doing the damage in the first place. So that's why antibiotics are important. Anti-inflammatories are there because when you've got a lot of corneal pain, you actually get something called reflex uveitis. So you get inflammation inside of your eye as a consequence to the pain of the cornea. It's a really weird thing. It works through one of the nerves, and they actually get an inflammation. So that's why we put them on an anti-inflammatory, because when they have inflammation inside of their eyes, their pupil constricts, because that's one of the problems with having inflammation inside of your eye. The pupil constricts like crazy, and it's really sore. It's like having a charley horse inside of your eye. And so they're very, very painful from that. When you look at the sun, you know how you think you're burning a hole in your eye, and that's why your eye is like super sore? It's not really. It's just that it's having a massive spasm. It's constricting so much to try and get the light out that it hurts. And that's what this would do. So that's what ulcers do, is they make them constrict so much they actually hurt. So that's why we put on anti-inflammatories. We also put on medications, this one here called Midriatic, which is a dilated drop to help relax it. And it just makes everything just calm down. It just keeps those blood vessels inside of the eyes from leaking all the time and creating more inflammation. And it just makes the horse a whole lot more comfortable. Sometimes we will use antifungals if we suspect that the ulcer has been caused or at least infected with a fungal agent. And fungals are really hard to treat. And then protease inhibitors. So those would be things that are going to inhibit the stromal license. What we use more than anything else is serum. So we just take it straight out of the horse. And it always seems like witchcraft. I get this look. It's like, you're going to do what? But yeah, the serum, not the blood, but the serum contains alpha-2 macroglobulins, and those actually actively inhibit the stromal-lysin activity of the bacteria. So it's cheap, it's free, it's readily available. Stick it on. I mean, this is what he needs. You can get other things, like acetylcysteine is a commercial brand. You can get a product, you can get ETA, you can use heparin, you can use a lot of different things, but those are all commercial. Sometimes you have to order them in. That one's getting a little bit hard to find. They're just difficult, and then you've actually got to go and actively get it and then bring it back. Whereas the horse is standing right there, just going, take my blood. And the beauty of these guys, you can't take it off. I mean, you just can't, and he's got it right there waiting for you, so it's really good. It's always a little hard when you've got a 3-pound chihuahua that's about to rupture, and you're trying to, they make your life a little bit hard. Make sure I didn't miss anything here. So far, so good? Surgicals. So surgical would include things like debriding or grid keratotomies. Those are for ulcers that are very, very superficial but just not sticking down to the cornea very well. We kind of have to boot them up because those are mechanical ulcers, so not even infected. They're just driving everybody crazy. So that's called a debridement. And that's with a Q-tip, or sometimes we'll take a needle and actually scratch the cornea, like grooving the highway before you lay the asphalt. It gives that overlying epithelium something to stick into so they heal a little bit better. Sometimes we do third eye like flaps. These are always a little controversial because you don't want to do the whole eye covered up because then your medications just toboggan off of it and go down to these glaucoma ducts. They don't actually get to the cornea. So we want to leave a little bit of a gap for medications to get onto the cornea. Conch grafts are my absolute living favorite thing to do. That's what this is here. And this is like a living Band-Aid. So you know the slippery tissue around your eye, the white? Take a little finger of that, keep it attached at one end, and we slide it across and suture it right on over top of the ulcer, over the defect. It's cool. I know. I get that look a lot. It's like, whoa. But that's what this is. So this is still attached down here. All the blood vessels are still running right into it like they always did. And what they do, that cut conjunctival tissue then, almost like laying sod, it grows little blood vessels down into the cornea and it just anchors. And all these blood vessels, or all these sutures going around here, they're all absorbable. You don't have to go and take them out. And this graft will be permanent. Sometimes in 3 months or so, we'll go down and cut the neck of that thing off. So then it's just this little living patch. But it becomes, because there's no blood supply now once you cut it, it becomes pale, a little more flat, and it'll actually just grow into the cornea. But it'll always have a scar. And that's something I get a lot of questions about. Well, I don't really want a scar on his eye. Well, my answer to that is, would you rather lose the eye? Because that's what we're dealing with. And if it's something small like that, he's not going to lose his vision. I mean, come on, you can see around that This is a little bit bigger, and sometimes they're much bigger than that even. And if we're getting to the point where a graft is going to be 90% of his cornea, then I have to go, do you want to do the surgery or do you want to just take his eye out? Like, what's the hang up? Is it that you're in love with the eyeball or are you in love with his vision? You know, and I get it. It's a tough decision to have to make. I mean, I'm not critical of that. It's just, sometimes there's a little bit of common sense that goes with it. Here's another one here. So these are highly successful surgeries. I love doing the contrast. This is a corneal transplant here. I'll tell you right now, so nobody's going to ask me to do a corneal transplant on their horse. Okay, you have to have a freshly killed cadaver to get a clear cornea. That's why with humans they have eye banks. Every cornea that they have in an eye bank is taken off a fresh cadaver. They don't freeze well. When they freeze, that very, very inner layer of cornea dies, and you need that layer to keep the cornea clear, to be functional. So we can't keep corneas alive long enough to do a transplant. So that's why when we do a corneal transplant, this would be an opacity. It would be white. Okay, I got this one off the internet. I don't know how they did it, but they didn't get it from a frozen cornea. That would apply to small animals as well. Okay, so it's tough to get these. And then the other question I always get running into is, where do I get a cornea from? Because, you know, the abattoir is not going to let you have them. We've had dogs who are, you know, about to be killed at the SPCA, and they won't let us have corneas to transplant to somebody else. So it's, where are we going to get a cornea from? So it's tricky. It's a tricky thing. But this is always a good option. Yes.
Can you, sorry, I'm a nurse, so I
Great.
bank stuff.
Oh, perfect.
Can you bank the other parts of the eye the way you can in humans for horses, or no?
Like which parts?
That would require me being awake enough to remember, but I know, I know in humans they bank pretty much a lot of the other parts of the eye that they might need, and I don't know if that's...
I haven't heard of anybody banking other parts of the eyes. I have heard of them banking things like placenta. Believe it or not, we use placenta or amniotic fluid bags to actually use as patches on corneas, which is really cool. It works great. But I haven't heard of anybody banking anything other than cornea. But I'd like to know about it. It'd be kind of cool. I'm just not sure of where you would apply it. We have synthetic material that we can use as scleral coat, which is really interesting. And the cornea has got one advantage over the rest of the parts of the eye, and that is it's avascular. This one's not avascular, but say this part here is. So there's no blood vessels in it, which means it's pretty antigenically sequestered. And so if we're going to take a piece of iris, which is solid blood vessel, or sclera, there's lots of blood vessels in those areas. So I think that would be a trickier area to try and transplant.
It's going to drive me nuts now.
I know, it's going to drive me nuts too.
I'll
So you
remember
have to let me know. You have to let me know. And then a keratoectomy is where you actually take off a portion or a third of the upper part, or sometimes the lower part, and slide the top over top of that, of the actual cornea, and you don't replace it with anything. It's kind of neat too. You can do that to get rid of an opacity or an abscess of some kind. Oh, sorry, that's me. I keep thinking there's something upstairs, I was going to get mad about it. An indolent ulcer, I was telling you before, is where you've got a surface layer of the cornea that's just not sticking down. So it tends to be these ulcers that go on. But they're very, very, very superficial. And you might even be able to appreciate that on here. This here is where all the stain retention is, but that's actually the size of the ulcer. And it's a tiny little thing. It's just that the epithelium that's coming up over the sides trying to heal is so loose that the stain just kind of bleeds underneath it. And that's how we can tell it's an indolent ulcer. So what we do to that is, like I said before, we kind of beat them up. Take a Q-tip and you rub the daylights out of them. Normally, if this was a dog, well, this is a dog, but if this was a horse, we wouldn't do the next step that we would do in a dog, and that is to take a needle and scratch the cornea to create grooves. I know it sounds gross, but you really need to do that with these guys because they're not infected, they're just simply mechanical more than anything else. But we don't do that in horses, and that's because the risk of fungal infections is so, God, if they get one, it's just not worth it. So, you know, we just only stick with debridement on these guys. It just keeps them a little bit cleaner. So let's move on to uveitis. Do you have any questions about ulcers? That was probably the longest section, so the rest of them are a little bit quicker. It's only because your ulcers happen all the time. Okay, so uveitis, remember I said, was inflammation of the uveal tract, so anything that has the blood supply within the eye. So that's the iris. There's a little body behind the iris called the ciliary body, and then there's the choroid, which sits right behind the retina. It's this big, fat blood vessel layer. So clinical signs of uveitis would be, and I showed you the pictures of them, would be the squinting, the redness, and the tearing. Classic. 3. Those 3 signs there are pretty much with most ophthalmic diseases or conditions, so they're very umbrella-like. They kind of fall under a lot of disease categories. The causes of uveitis are ridiculous. There are so many causes of uveitis. Anything from, like I tell this to dog owners, anything from an ingrown toenail, skin disease, full-blown cancer. It can be anything that causes it, and that's because the uveal tract really does communicate with the rest of the body. So all the blood that's going into your body and circulating and having inflammatory responses for whatever reason goes into the eye and tends to kind of sit there. So bacterial, algal, fungal, yeast, immune-mediated metabolic traumatics, parasitic, neoplastic, prosol, and viral. And then I actually took out a section that was called miscellaneous because it just seems silly. And I thought, what, somebody's going to put up their hand? And it's like I couldn't actually readily come up with something that said. The way we treat them is with anti-inflammatories and treating the underlying cause. So uveitis inside of an eye does not necessarily mean you need to put antibiotics on top of the eye because there's no ulcer. So how is that helping you? You do need to put an anti-inflammatory on her unless there's a secondary problem whereby you've got an ulcer. Because if they have an ulcer, you can't treat them with an anti-inflammatory on their eye. It's all very complicated. So we really go a lot with oral anti-inflammatories. We often will do an oral antibiotic, and sometimes we'll do an oral antifungal. But those are expensive as anything, and we try to avoid those unless we know there's a real reason for it. Consequences of having inflammation inside of your eye, and by the way, you make too little fluid when you've got inflammation in your eye. You don't tend to make fluid. Kind of the eye just kind of goes, oh, I don't want to do anything. So it doesn't make fluid. And you normally make and lose fluid all the time. It's a big convection current inside of your eye. But the consequences to A, not having fluids, you've got this stagnant, inflammatory fluid inside of the eye, are that you can get cataracts, glaucoma, and you can get blindness as well. You get the cataracts because your lens, which actually has no blood supply to it, it's a solid, clear, sitting in space little orb, sitting in a nice bath of lovely fluid. If that fluid is inflammatory, it's like a fish in a fish tank. That fish is going to die, and so the lens dies, and it turns into a cataract. And that's no opacity in the lens. Glaucomas happen because you get scar tissue inside of the eye. It disrupts that whole fluid convection current I was telling you about. And then the problem with that is you get build up of fluid or lack of exiting of the fluids, and that causes glaucoma. And then both of those can cause blindness, or you can actually end up with retinal detachment. So it can end up progressing if it gets really out of control. So that's why you need to get on board with these things very quickly. Okay, you might have all heard of equine recurrent uveitis, moon blindness. I don't see it a whole lot here, which is kind of nice. It's also called moon blindness, periodic ophthalmia, iridocyclitis. It tends to happen more in Appaloosas. It doesn't always happen just in Appaloosas, so don't think anybody who doesn't have one is off the hook because you're not. It's just that it tends more often to happen to them. It can be unilateral or bilateral, and it is manifested as an intermittent inflammation inside of the eye, and it tends to come on 12 to 15 months after some exposure. Now, that's the golden question, what's causing it? Well, the reality is we don't know what's causing it. There's been so much work that's been done. The big culprit that everybody seems to always land on is leptospirosis. There's a number of different serovars that are associated with lepto. There's one serovar called Cornea that it seems to always get the bad rap, but every other serovar has been implicated in the past, so it's not just that. Really, it's any inflammatory antigen that then sets up an immune response inside of the eye that it mimics later on. So in other words, you can kill, let's call it lepto, let's just say that. We kill the lepto. There's no lepto in this horse whatsoever. Titers have been done, everything else. But this horse will still have recurrence later on. And that's because it's not the lepto that's doing it, it's his memory of it that's doing it. And it mimics his other cells. So that's why it's so frustrating, because how do you get on top of that? How do you treat that? So we don't. All we do is treat the signs when it comes up. We're not actually getting rid of the problem. We're getting rid of the signs, and we're hoping that during these outbreaks of inflammation, that we're not going to then set them up to have scar tissue that then is going to result in cataracts, glaucoma, or blindness. We're trying to just sail them through it, and then wait for the next one. So it's a real cyclical, and that's why they call it moon blindness, because in the past these have been happening before moons and blah, blah, blah. And some horses have it once a year, some horses have it once, some horses have it every month. It's just ridiculous. So that'll be manifested, as with other uveitis, with tearing, squinting. Photophobia is just because everything's irritating for the eye, but bright light is painful for our eyes. And often meiomyiosis, the constriction that I was talking about. And sometimes with scar tissue, that pupil shape won't be oblong anymore, it'll be all screwy. You often get corneal edema, but the corneal edema, remember with the ulcers how it was focal? This would be more diffuse. And it's more diffuse because the problem isn't on the outside of the cornea, it's on the inside of the eyeball, so it's the whole thing. Why would the fluid only be inflammatory in one section? It wouldn't, it would be the whole thing. The conjunctival tissue gets red, and that can be really prominent later on. And then, like I said before, this can develop with glaucoma, the cataracts, retinal detachment, degenerations, that kind of thing. Okay, and I'm going to talk a little bit more about this later when we talk about cataracts, just so you remember. So here's a picture of what I was talking about with this immune-mediated or hypersensitivity reaction that's going on inside of the horses. Some sort of antigen, so some bug, virus, bacteria, we don't know. Lepto is the one that's implicated the most, but it can be anything from toxo, brucellosis, streps, E. coli, rhodococcus, borreliosis, parasites, virus. We don't know what it is, but every single thing has been implicated in some horse that has uveitis, so nobody's really ever figured it out before. That stimulates the horse's immune system. It also, at the same time, causes active inflammation. When we treat them with medication, we're getting rid of this part. So that's how we're stopping the active part from this. The problem is we're still dealing with this. And this antigenic mimicry is what's always causing this recurrence. And the other problem we have is, well, what stimulates the antigenic mimicry to go? Why is now is eating bug? What's causing him to have this reflare? Why is it recrudescing? We don't know. It's really weird. I personally like to think about them as almost like feline herpes, because fat cats, by the way, have herpes. They all have herpes. So do horses, but just not as much. But we don't know what ticks them off, so they have this recurrence of this tearing and squinting up. So we think it's stress related. Is it? I don't know. I don't live inside a horse's mind. I don't know what makes them stressful or what makes that horse stressful and that horse not stressful. I don't know, and we just don't know the answers to that yet. So what we're faced with at this point, and we have been for a while, is we're faced with dealing with this here. When they recur, we have to deal with that, and that means typically oral anti-inflammatories. If they don't have an ulcer, then we do topical anti-inflammatories, dilating drops, and we try to just get them past it without getting any kind of scar tissue inside of the eye, because it's scar tissue in the eye that we can't deal with. That's just no man's land. You can't unpick scar tissue. So we're always trying to prevent scar tissue, and that's through trying to treat these guys here. Does that make sense? As much as possible, because we don't have all the answers to this at all. Okay, so testing it, in terms of testing for the inciting cause at the time of any kind of active uveitis, so let's say it was day one of active uveitis of your horse, never had this in the past, this is the history of him. What would happen is there would be some blood samples taken, maybe some biopsies, and maybe some aqueous humor aspirates, that's the fluid in the front of the eye, to see if any kind of antibodies can be determined from that, or measuring loads inside of the eye. As far as treatments for equine recurrent uveitis, so later, if there's a specific treatment that's been identified, or a specific bug that's been identified, you treat for that, obviously. And then we're treating for general uveitis and the secondary changes. So if he's developed glaucoma as a consequence, obviously we're going to treat for glaucoma. So you're trying to ride them through this outbreak that he's had until the next one happens. Some horses need to be on anti-inflammatories like chronically, others just intermittently whenever they're having an outbreak. So it really depends on the horses. All right. Prevention. Now, what we know is that if we're controlling vectors, so the parasites, wildlife into your paddocks, rodents getting access to feed, we know that whatever is getting into these horses, hopefully the transmission is going to be decreased. So keeping a nice clean barn, good fencing, that kind of thing is always helpful. Obviously reducing exposure to infected urine and contaminated feed, so swamps, ponds, any wildlife can get into, and again, that's really revolving around the whole lepto side of things, but there's other ones too, like toxo as well. And then vaccinating with a leptospiral vaccine, and this one is controversial. Some people don't go for that, other vets love it. I'm not certainly going to offer an opinion on it, because it's whoever is looking after the horses, it's your call, really, you and your vets. So I don't really have a good answer for should you or shouldn't you vaccinate for these guys. Do you normally? You don't normally. Yeah. And I think I've heard that a lot. There's some areas where they religiously vaccinate. gee, which serum are you going to vaccinate for? And then you're saying multivalent, but is that all of them, or is that just some of them? I mean, how do you know you're doing the right one? It's a tricky one. The prognosis for it, in all honesty, overall the outcome is very poor for these guys because typically they'll develop cataracts or they'll end up with glaucoma. But if you get onto them early and you treat them aggressively and you're keeping the active inflammatory signs under control and they don't develop the scar tissue, my thinking on that is it's actually pretty good. So it's all about diligence and watching, just knowing that this is what his problem is and this is what we have to treat with. Because it is potentially blinding, it may require removal of the eye down the road. Any horse with equine recurrent uveitis clinical signs, so scarring inside of the eye, if it's ever been documented, they are considered unsound. They won't pass a wellness eye exam because you just can't hide it, unfortunately. You just can't hide it. All right, conjunctivitis. I was asked to put this in recently. Oh, it's such a nice topic. So conjunctivitis is a huge topic because there are so many causes for it. This is just some of the signs. Sometimes they'll look bright red, sometimes they'll look just this faded pink, sometimes it's associated with mucus, sometimes it's just a whole lot of tearing, sometimes there's crustiness, sometimes there isn't. And sometimes it's just the conjunctiva, sometimes it involves the cornea as well. So conjunctivitis or inflammation of the conjunctival tissue is just a very wide subject. I brought a list of causes of conjunctivitis, and I know I haven't touched on all of them. But by definition, it's non-specific, it's an indicator of inflammation, and that can be infectious or non-infectious. So inflammation does not mean infection. Inflammation is different, infection is infection. So inflammation can be from that or not from that. The causes of it, like I said, are numerous. So low tear production can cause conjunctivitis. You can get infection with bacteria, fungus, virus, parasites. You can have cancer. They can be allergies, or they can be secondary to trauma. Even just rubbing. You know, if they're bugging on the eye overnight, they can get a tremendous conjunctivitis because that tissue is so vascularized that if you start bugging it, even with your own eye, if you were just be rubbing on your conjunctiva, it's going to be really red and swollen, and that's just what it does because the blood vessels are all getting irritated. To diagnose it, do an ophtho exam. Sometimes you have to biopsy, sometimes you do cytology, sometimes you do culturing, like a biopsy in place, and then blood work. So there's a number of things that can be done. Sometimes you don't have to do anything. Sometimes you look at it and kind of go, oh, I know exactly what that is. But if you don't, and more often than not you don't, then there's other ways to find out what the answer is. The risk factors associated with conjunctivitis would be the weather. So hot, dry, dusty, that kind of thing. If there's lots of flies in the barn, because they're going to transmit everything all over the place, from one horse to another, to one eye to the other. Parasites, so Havernema, psoriasis, pigment. The pigment being that if they are really albino type of horse, so they don't have very much eyelid pigment around their eyes, they can get conjunctivitis, they can get other things as well. And then if they're sick and laying down a lot, we see that with foals, the ones that are just not doing well, and they're always in the hay, they tend to get a lot of conjunctivitis. Okay. So I kind of went over that quickly, but that's really because it is so broad, and I'm happy to talk about questions associated with it if anybody has any that are a little bit more specific. Cataracts. Okay, so I get this question a lot. My horse has cataracts, what do I do about it? Well, cataracts are an opacity in the lens, and it can be partial or it can be complete. Most cataracts will progress to being completely cataract, just the whole lens, as opposed to just part of the lens over time. The question is, how long will this cataract take to progress? And the reality is, I don't know. Every cataract is a little bit different. If there has never been a history of the cataract not being there 2 months ago and now it's there, then my prediction would be, say, well, it's probably going to double in 2 more months. But if somebody just notices it and it's tiny and they say, well, I don't know the horse's age, I don't know how long it's been there, well, then my answer to that is, I don't know how long it's going to take to get to maturity. So we just have to watch and see. And what I usually do with them is say, well, let's check in 1 month or 2 months and just see where it's at that point. Maybe we'll get an indicator of some change. They are uncommonly inherited in horses, which is a good thing to know, but the bad thing about that is that they're usually acquired, and that can be from trauma, which is really the best case scenario, or acquired secondary to that equine recurrent uveitis that I was talking about before. And that would be bad. When they're treated, lenses are removed. We don't have implants for horses, like the false lens implants that we use for dogs, so they are farsighted after that. Functionally, though, they're actually really good as adults. The only horses that I have ever, I've done horses for cataract surgery. The only thing is with them is that they have to be less than a year old. And the reason we do that is because they're so big that you have to be able to get them under your microscope, number one. And the needles that we use to take the lenses out, they really have to be a lot bigger, and they're hard to find. And so you have to pre-order them or get them ordered for these adults because the lenses are just so big, you just can't quite get in there and dig them out. So what I do when I see horses here in the Lower Mainland is I tend to say, I think Saskatoon would be your closest choice, that or Washington. It seems a little bit like, wow, I have to leave the province to get cataracts out of my horse, but unfortunately that is the reality. Now, the number of horses, though, that actually end up taking that journey is very, very small. In fact, I think in the 8-9 years I've been here, I don't think more than one has ever gone across border to get cataracts done. And the reason that is because in adults, they're almost always secondary to some sort of inflammation, typically equine cornea uveitis. So if they've got scar tissue inside of their eyes, if the iris is very dark in the eye with the cataract, as opposed to the other eye, or the granulum retica is very small, those are all signs of chronic inflammation inside of the horse. And nobody will do cataract surgery on a horse that has chronic inflammation. It's just not going to happen. If the horse looks clean and lovely and there's no signs of inflammation or no history of recurrent uveitis, then we'll do what's called an electroretinogram and measure their retina's ability to convert light into electricity to go to the brain and make sure that that works well. But if that's a deficit, then we don't do cataract surgery either. Because doing cataract surgery in those horses would be like taking the lens out of your camera and knocking the film in it. Changing the lens. It would be silly. It looks cosmetic, but that's really about it. Pretty clear? So it's kind of a little bit of bad news, but it is what it is. When you take lenses out of a horse that's less than a year old, they have about a 60 to 80% chance of having functional vision afterwards. So it's not bad. It's not nearly as good as a dog, but you are talking about an animal that doesn't often have it done. So you're talking also about fairly inexperienced surgeons, and also just the fact that they're horses is more difficult to do. If you're talking about an adult who's a good candidate and he ends up going in for cataract surgery, they have about a 50% chance of having good vision. So it's a risk to do cataract surgery in horses. There's no doubt about that. Glaucoma. Now, this one I've highlighted as an emergency because really it is. Glaucoma is not something that any animal deals with well. They lose vision very, very quickly. You might have somebody, a relative or yourself, who has glaucoma, and you kind of fester along for a year or two with these slightly increased intraocular pressures, and you're on all kinds of medications. And that's fantastic for people. It doesn't work that way in horses and cats and dogs, and especially dogs. They can go blind in 12 hours. Horses can go blind very rapidly too, not usually in 12 hours, but nonetheless they can go blind if the pressures go high enough. So they can be primary, and that would be the inherited form, and that's really where the drainage angles aren't built very well, and so the fluid's having a hard time getting out. Or they can be secondary, which is acquired, so from inflammation, scar tissue within the eye. And this is really by far the more common cause right here. So by definition, it's not one thing, it's actually a constellation of clinical signs that all come together, but all those clinical signs result in an increase in intraocular pressure that goes beyond the limits of compatibility with health of the eye. So you can have increased intraocular pressure, it doesn't mean you're not going to go blind, but if it's beyond what your eye can handle to maintain vision, that's when you go blind, and that's when we call it glaucoma. So some of the clinical signs that we see, oopsie, I'm really bad at this, would be a dilated pupil, or a pupil that is dilated and very slowly responsive to light. That's never a good thing. Or you get this diffuse grayness, or redness. And remember, so redness, and then they're squinty and they're teary. So redness, squinting, tearing, that's such a blanket statement, but you have to take it seriously every time. But the diffuse grayness is fairly common with, well, it is common with the glaucomas, and it's pretty uncommon to have it with anything other than maybe a really bad inflammation. The dilated pupil is the one that's a real giveaway. If you've got a dilated pupil, there's a problem. Okay? And I don't mean just in the dark and shine a light and constricts. That's not what I'm talking about. So I'm just talking if you have a light and it doesn't. The giveaway for an old glaucoma, or perhaps even a common one, are these little white stripes. They're stretch marks. And they don't always come in a cross shape. They can be in just a single line that goes across. That's a break in that red decimase layer that I showed you the picture of originally. That's one cell layer thick, and it does not deal with stretch at all. And when it stretches, it actually breaks apart, and then you get fluid that goes in there, and it creates a permanent line, whether it shrinks again in the future or not. That'll be a permanent thing, and the only way they can get that, unless they've had, and I've seen this like twice, I think, unless you've had a really bad blunt injury to the cornea where it actually pushes it in really hard, Sometimes you'll get a split in the desmase from that, but more than any other time, you're going to get just secondary glaucoma. It's kind of what happened to my sign. We just look at it and go, that's not a good thing. Fortunately, we don't see a lot of glaucomas in horses. Hit the odd one, but we don't get that much. Sarcoids. Yeah.
My dog's got the glaucoma now. Is this something that's going to happen right away? I never had problems with it. Is it like you're trying to describe it? But
Yeah.
wait, does it just come on, or was there something cooking there that nobody
You
noticed?
know, for dogs especially, 99% of the time, if it's going to be bilateral, it'll be one eye first, and they'll be like, whoa, what is that? And then we just say, okay, your eye's blocked, let's move on to the other one. So we just have to focus on the second. It's that quick. It's brutal. You just don't notice it. I've had horses come on super quick as well. More often than not, because they're secondary or acquired from something else, there's preceding signs, like they've had an equine recurrent uveitis, or they've had this weepy eye or a lot of inflammation. So often there's something that's been cooking away there for a little while to cause that. But the dogs, yeah, for no reason, just boom. And it's brutal. Hate that. Sarcoids. Okay, so these are actually tumors. And they can be solitary or multiple. I don't know if anybody's ever had a sarcoid or seen one. Yeah, they just look like these weird little knobs. I don't know. They can sometimes be really hard. Yeah, sometimes they break through the surface and they look all lumpy on the surface. I've got a few pictures of them. They're usually in horses that are younger than 7. We don't again know the cause of these. Think it's viral. Flies are thought to be the vector on these things. So dry barns with lots of dust and flies in them. Sometimes a fly mask will make a difference. And we think that the flies help with this because they'll take sarcoid cells from one area and move it to another, and they just kind of spread. And they can move it to the next guy down the road. They're just kind of a pain. They're hard to treat in my experience. I've got some pictures here. So there's different types of sarcoids depending on what they look like. They can look all really quite excoriated, almost raised and bumpy. Other times they're very smooth and almost hard to see. I'm going to show you the periocular ones. They can happen anywhere. And there's lots of treatments for them, and that's because nobody knows how to treat them, so everybody's got their own way. And that's typically, if you have a disease with lots of treatments, is because nobody really knows the best way to treat them. Cutting them out is one way. I've certainly done that before, and then you freeze the daylights out of the site, and you close it all up, and you hope it doesn't come back. That often works pretty well. You can inject them with immunotherapy or chemotherapy to try and get rid of them. One thing that I did a study on when I was a resident was cutting them out. You have this nice open site, and then you burn it a lot. And you actually close it up again. And, that makes no sense. If you did that to you or your dog, you'd have a horrible infection or an abscess inside. It's really, really gross. But for some reason, these guys do really, really well. So I don't know the magic. I just know that worked. And then we started doing other studies where just on the outside of the sarcoid, without actually debulking it at all, we would burn it from the outside. And it was almost like using a little, what are those soldering irons? It was almost like that. It wasn't a soldering iron. But you make little burns all the way across it and all over it. And it would actually break these things down and kill them. It was you had to do it multiple times. This wasn't a one-off thing by any stretch. But it was tough. They were hard to get rid of. And I'm glad we don't see them very much here, because I think that's all I would do. Sarcoids. Well, that's all you would do anyways. It's so sad. So treatment is surgical resection and immunotherapy. Freezing has been done, heating has been done, laser excision has been done, radiation, autologous vaccines, those are a bit anecdotal, we don't really know if they work. So the message from that, whenever you see everything with lots of treatments, is we don't know. This works in that guy's hands, and that works in this guy's hands, and that works in my hands. I mean, it's just, the problem is we just don't know what the reason, what the best way to treat them is. Squamous cell carcinoma. This is one that always makes everybody cringe when they hear the words. These are ones that we see a lot, or more often, in lightly pigmented animals. So your albinos or your Albies, or somebody who just doesn't have a lot of pigment on their skin. The reason we see that is because it is thought to be exacerbated, strongly thought to be exacerbated by UV light or even caused by UV light. And that's because UV light inhibits, there's a gene that you have called, I think it's called P53, that is a tumor suppressor gene, and UV will actually inhibit that suppressor action, so they end up getting this problem, unfortunately. It does, like I said, occur in the non-pigmented skin and membranes. Those are the areas that are more susceptible. It doesn't just happen around the eye, it can happen in other areas of the body. Colored dilutes are big. Draft breeds are huge for this. I see a lot, and I saw them more in the southern U.S. I really haven't seen a lot up here in BC, thank God. I'm so glad we don't see a lot of these things up here. It's crazy. Very little in Arabs, thoroughbreds, quarter horses, bays, blacks, browns. So maybe you've got one. The prevalence does increase with age as well as with altitude. So if you're in a really high altitude area, and again, it's all UV related, then you can expect to see more and more of that. It shows up as this kind of pale pink, very oscillated, fleshy kind of tissue that grows, and it can grow right at the limbus, like onto the cornea slowly, or it can just grow right in the conjunctival sac. Those are the third eyelid. Those are really the more common areas to go with. When I tell them, when I see them, I'm sorry, hitting myself. I keep thinking there's something upstairs. When I see them, really what needs to do the first time that anybody sees them, honestly, is to take a piece of it off and biopsy it and send it in to say, what is this? Is this really what this is, or is this just what I think it is? Because it can look like other things. It could just be a very aggressive-looking conjunctivitis. It could be who knows what, parasites. There could be lots going on with that. So you got to find out what it is before you go in and trying to treat it and giving bad prognosis for things. I'm sorry?
Does it really hurt the horse when that's happening? I know an older horse that has that. He's had it for a few years, and it does affect him in any way.
I'm not so sure it hurts them. But the thing about squamous cell is that it can travel to the rest of the body. And it can travel to the lungs, and it can travel to the internal organs. It's bad. It's one of those bad tumors. So it is better to try and deal with it earlier than later. So we see it on eyelids, third eyelids, conjunctiva, and limbus. Limbus is where the clear part of the cornea meets the white of the sclera, even though it's the same tissue, but there is actually a little junction there. And you do see it as reddening and roughening. Sometimes you get ulceration, but you'll often get a lot of tearing as well. And it is typically small and pink, or sometimes it's red, but then it does tend to spread quite a lot, and it can spread behind the eye as well. And that's where things get a little bit tricky. So if you cut it off and it comes back, sometimes what we say is, look, in order to try and really get this out, we talk about enucleating the eye, so taking out the eye, and actually scraping the orbital bone to try and get as much out as possible. It's really not a very good thing. It can get into the sinuses as well as the bone, brain, and really the rest of the body. So it's not a good one to have. The only way to truly diagnose it is through a biopsy. So that's why I say the earlier the better. Find out what it is. Just try and get as much out of it as you can, so that we're not going to continue to deal with this forever and ever, unfortunately. I heard a little interesting test that you guys might know is if you put a urine strip under the lid when you have a suspect, you'll see occult blood in it, which you won't have from something else like a fibrosarc or something like that. It's kind of a tip, little practice tip I learned about. Okay, so treating, it really depends on how big it is, where it is, what it's invading, does the horse have any vision, what available equipment do you have, and also the financial constraints, because I'll tell you, squamous cell carcinoma can get expensive if you're going little bits at a time. It can get tremendous. Surgical removal of the tumor is really the only way to do it. You should be following that up though with freezing or heating, radiation, chemo, and it is likely to occur and require additional removal. So I never, ever, ever taking off the mask tell anybody that it's going to be their only surgery, because it probably will not be the only surgery. Really, the only thing is how often you have to do surgery is really what you're looking at. So the prognosis for it is pretty good. If it's really small, you get it all, or at least you think you do, and then you treat the site afterwards with, like I said, freezing or heating or chemo or anything. So to reduce the risk, if you do have a lightly pigmented horse, avoid the sun if you can between the peak hours. Fly masks are good. Sunscreen is great. Some people will even tattoo the eyelid margins. I've never had to do that, but that's an option that's out there. Okay, miscellaneous things. I just threw this in because they're funny little things that people often ask about. So you've probably seen these guys, the little pigmented balls. Those are just iris cysts. They start behind the iris, so attached to the inside of the iris next to the lens, and then they kind of work their way up to the edge of the iris where the pupillary margin is. They become a little ball, and they often just hang there or dangle from the top. Sometimes they'll fall off and they'll fall into the anterior chamber at the bottom, kind of like a beach ball. If we have a dog, I love these in dogs, usually golden retrievers, because they'll actually bounce around and you can move their head around. So it's really cool. So people often come in thinking it's a melanoma or something scared. And of course that's the differential for it. Absolutely it is. But if it's fluid filled, and certainly if it's detached, it can only be a cyst. So those are good things. We don't know why they get them. Some horses get them just because they get them. Other horses get them because they've had a chronic inflammation in their eyes, and that can cause iris cysts to form. There really isn't a treatment. I mean, you can laser them, and don't get me wrong, horses are probably the only ones I ever would laser, because they tend to grow from the top granular iridica, and unfortunately for these guys, is they'll then have this little beach ball of pigmented, well, it's clear fluid, but a pigmented beach ball on the outside, and it dangles in the pupil, and he's trying to work during the day with this thing in his eye. And it's like, oh, I mean, that's not good. So, you laser them and it pops it and they go away. If you're lucky, they start at the bottom of the eye, and then they just sit there, and they don't do it. They don't hurt them. When they pop, they don't hurt. They don't actually cause a problem for the horse. So if we can avoid doing anything with them, we do. There's been reports that you can put a needle in the eye and puncture it. Never had to do it. Most of the time, I just leave them alone. The odd time I've had to laser one just to pop it, but it's not a common thing. You don't need to be doing that a lot, and they really don't get them that often. You get some, but they're really not. The only reason we would treat the horses is because, again, you're dealing with a vision obstruction, and because you're dealing with the horses during the day, and you're not out playing with them during the nighttime, most typically. So the fact that they're in their pupillary space and obstructing their vision is kind of a problem if you're on their back. So those are iris cysts. The other one that you've probably all seen will be the heterochromia iridis. This is just the pigment variation between eyes or within one animal. So instead of just being a monotone brown or dark brown, you'll have some flecks of blue or a whole area of blue. And then they've got the special names, the walleye and China eye, they go with that. They don't mean anything. They don't have any bearing on their function. Sometimes decreased pigment can be associated with reduced function or malformation within the eye, but that certainly isn't a blanket statement, and it's far less applicable to horses than it would be to dogs, for example. So you're going to see that more often in the lightly pigmented animals, like the Appaloosa, the chestnuts, grays, spotted, whites, those types of guys. So they're just pretty. Sorry. Oh, my goodness. Okay. Just make sure I have more of these. I had my little cheat sheets here for the odd slide that I might want to add into, but I think I covered them all, which is good. Okay, so let's get into some fun stuff. Traumas. Eyelid traumas. So eyelid lacerations are really common. I don't know if anybody here has ever had one, but they bleed like crazy. And you look at these and you go, oh my God, he's dying, his eye is out, he's going to rupture. Oh, this is bad. They're actually phenomenal because this is actually, it's just conjunctival tissue and they bleed a lot. But once you wipe it away, I mean, this guy doesn't look so bad, right? I mean, it's not bad. The one thing, this is a pretty big one here. The top lid is a lot more important than the bottom lid. So the top lid is what's responsible for really covering up most of your cornea and doing all the work. So we really fuss over the top lid. We fuss over the bottom, both of them. You don't want to ever, so if you're in your barn and you're worried, what should I do? Don't ever cut this off, ever. Because some people do, and it's really brutal. You have to have your eyelid margin. You have to. You can't make a new one. Well, you can, but they really don't work very well. So just all you do is you keep it clean, you keep it wet. If you have some antibiotic ointment at home, slather it on top of that. Just leave it alone until somebody can come out and repair it. What happens is this here would then just get sutured right back up into place, and it heals beautifully. So you don't have to, they swell like crazy again because they're heavily vascularized, but that's normal, that's okay, that's just healing response. But the key message that I wanted to tell you before this was don't cut it off. I've seen that happen before. It's a disaster because I will almost guarantee that if you cut the eyelid margin off, you're going to lose the eye down the road. The eye will come out because you have to have it covered. It's like having a windshield without windshield wipers. You have to do it. You just have to keep it. So keep it cool, keep it clean, compress it if you need to try and get the blood cleaned up. Try not to touch the cornea in the process because you can create an ulcer that way. Just cover it up with antibiotic and then call your vet and they'll come out and suture it or I will. Okay? It's really important.
What if you had to transport?
What if you have to transport?
Yeah, you're not near a vet.
Well, that's okay. That's all right. You can still transport. I mean, if you want to put something like a fly mask on him, you can do that. I wouldn't worry about that so much for him. But really, unless he's a ding-dong and he's going to be whacking his eye, you know, really, he'll be okay. If you just put a lot of antibiotic ointment on it, he'll be okay.
Any particular one?
Well, I've got my favorites, but you'll probably be dealing with something just over the counter, like local from well, I need something quickly. The polysporins work nice. You know, if you're in a pinch, get something, because that's not a prescription, it's something you just get over the counter. And it's just something to keep it. It's really more, I like an ointment because it's really more about keeping it clean and free of dust and dirt and flies and anything else is going to get stuck on there. So you want to just try and keep it moist more than anything else too. So you can put an antibiotic drop on it, but you're going to have to do that a lot. So, and the other thing too is that the antibiotic ointments almost tampen out it, so they almost stop it bleeding, which is really cool. So that then doesn't make it look so disgusting. They won't die of this. They won't die of blood loss. They might look like it, but they're not going to die of this. Corneal lacerations. These are kind of neat, actually. So that would have been one that was repaired. This is actually iris tissue coming out through a corneal incision, or laceration. This is a little tiny corneal incision. This is a human being. This is kind of interesting. Again, sutured up to both, and this is a conch graft over top. So you can either suture them up primarily, if it's just a little thing like that, or even like that, just primary sutures will usually do the trick. If it's something that looks a little worse, a little gappy, or you're not sure about the integrity of these, then we'll often just stick a flap right on top of it. You have to suture it primarily and then put the flap on top of it. So it's just a way to keep it in one piece. Iris tissue almost always will come out because the pressure inside of your eye is different than on the outside. So it's almost like putting a little airplane hole like in the window. Everything sucks up to the window. That's what iris tissue does, thank God. We love that because then it acts like our little flower. We'll pick that out. It gets pushed back in. But yeah, that's a really good thing. So this is a picture of iris tissue coming up. Don't ever worry. Don't lose the farm on this. Just clean it off. Regular old saline. Even just nothing on the eye or just a little bit of water on a face cloth around it, not on it, would be great. If you have any antibiotic solution, that would be great. Don't put ointments on these guys because the ointments will get right in through the cornea and into the eyeball. We don't want that. That's petroleum inside of the eye. So just any kind of antibiotic drop. If you don't have it, don't worry about it. It's better not to treat than it is to treat inappropriately. Don't put steroids on them. Just leave them alone. Just call one of these guys. Okay, so those are not uncommon. This one, I think, actually was a photograph, if I'm not mistaken, or at least it looked very similar to that, from, oh, this was so bad, a farrier who was just trying to deal with this horse, and he didn't hit the horse. It wasn't like that at all, but he had, you know, the twitches on the stick, and he kind of just went like this, but it kind of went like that. And it was just a bad place at the wrong time thing. It was just one of those things, but, and his horse did really well. They healed very well, which is pretty awesome. So when to call your vet? Increased or persistent squinting or tearing. Those are really big. So tearing is a big one. Redness, persistent, is a big one. Rubbing is a big one. Any obvious trauma. Or obviously you need a pre-purchase exam. I don't know why I missed squinting on there. It's such a common thing. But squinting is a big deal in every animal. So dogs, your dog at home, if he's persistently squinting with one eye, cats, horses, you're talking about a prey animal. And if they're walking around squinting, it's a big deal because something is bigger than whatever it is might be eating them over here, right? That's how I always look at it. They just don't fake squinting. And I don't mean a little twitchy, they've got something in their eye and they're going like this. I mean like they're walking around like this. That's not a good thing, okay? If your vet requires a second opinion, they'll refer. Okay, pretty clear? And then there's a whole lot of references. I always say, avoid the internet, and here I'm guilty, I've pirated most of these off the internet. But what I say when you're looking up stuff on the internet, go to a university-based site or go to a vet site and look for information. And I say that because, quite frankly, nobody writes the good stuff. If you go to a public site, it's just not in anybody's best interest to write a love story on the internet. They write the bad stuff because it gives, it's more dramatic. It's, oh, look at my horse. Don't do that to yourself because I get myself all bent out of shape when I do that. Just go to a university-based site. It's very boring. It's just the facts. They'll show you good pictures and you can apply it to whoever it is that you're interested in. That's probably the best piece of advice I can ever give anybody is university-based or clinic-based sites. Okay? Does anybody have any questions? BNPH is fine.
Could you repeat the question, please?
Yeah, sorry. She wanted to know when would be an appropriate time to use BNPH ophthalmic ointment. And great, because we do use it, although for a while it was off the market. It has hydrocortisone on it, so it's a triple antibiotic, but conjunctivitis or eyelid swelling. But you really don't want to use it on an ulcer because it's got a steroid in it and it will make an ulcer worse. So steroids and ulcers don't mix, ever. So you can use it topically when you're not dealing with a corneal issue or a corneal ulcer. So only if somebody has said to you, this horse doesn't have an ulcer.
So in other words, you have your vet check it out first.
I think it's always appropriate before starting a steroid. I do, just to make sure there's no staying retention more than any other reason.
BNP, the regular appointment, not the
Yeah.
steroid, it's not available anymore.
I know.
Yeah, just found that.
No, I know, and it's been on for a little while now.
Yeah.
There's other options out there. There's a number. I like Tobrex. It's one of my favorite ones, I think.
What was that?
It's called Tobramycin or Tobrex. It's a good one. Yeah, the regular old BNP, it hasn't been around for a little while now, and I don't know if it's coming back. I haven't heard any word on that yet. It's frustrating. It's a good kind of go-to drug. Any other questions? Yeah.
Years ago, I actually had my own dog. We got a scratch on the cornea, the eye deflated. Most of that time, put a soft contact lens on, re-inflated the eye. I'm just curious, we don't see corneal lacerations all that often.
Yeah.
Has that ever been tried on a horse or?
Oh, putting the contact lens on? You know, the contact lens just by itself with laceration in a dog even, I wouldn't do. I would still suture it primarily. I would do it on a superficial ulcer to try and get it to, because what the contact lens does, he was asking about putting contact lenses on corneal lacerations, and this was done on his dog successfully, which is fantastic. I wouldn't do it on a full thickness of anything because there's going to be pressure in the eye that a contact lens is not going to be able to deal with. It provides comfort, which is awesome, because then the lids aren't going over top of this ouchy part of the cornea. When it's on a superficial ulcer, those contact lenses will stay on to some degree. There's a different corneal curvature for a human soft contact lens, and these are, I'm talking about the dissolvable collagen therapeutic lenses. I'm not talking about your contact lens with a prescription. They're a little bit different. We do have some for horses. They're more sized for a dog though, so it's not going to cover up the whole thing. And so to keep them on, we'll suture up the third eye like partially. We even do that with dogs because they fall off so darn often. But again, it's really for sorry, I need to let it go. It's really for superficial ulcers than for deep ulcers more than anything else.
This is kind of anecdotal, but I'm just curious because we have a 25-year-old thoroughbred mare who is having the ERU incidents every 4 to 6 weeks, and it's getting very boring. My employee who lives on the internet found something called Guardian Mask because it seemed to be, for summer months, it seemed to be sunlight related, and since using that, when she's turned out, it seems to have reduced the incidence by 4 to 5 fold.
Okay.
Does sunlight cause this to come back?
I don't think sunlight causes it to come back. Again, we don't really know what the initial inciting cause of it was, but I don't think sunlight is causing it. It probably exacerbates it. So when she's getting it kind of a start of an outbreak and then she's outside, it's probably making it worse, so you're seeing it more. It could be that she's still having little suggestions of outbreaks, but it's not really blowing out for you, so you're not finding that she's having an outbreak as often. Do you think that's possible, or do you think
It's also been interesting that she's learned to go into the shed.
Yeah, well, they do get a photophobia when they have inflammation in their eyes. That would be the same as you too. So that I'm not really surprised by. It's making her a lot more comfortable to be out in the sun. Because her eye is already under some, well, it's not really under pressure, but it's under some duress when it's under the sunlight because the pupil is then constricting upon constricting. So it's more painful for her to be in the sunlight. Yeah.
Marnie, sorry,
It's okay.
would you repair a cornea standing?
Would I repair a cornea standing?
Yeah, the laceration that you show.
You would.
No, I wouldn't. Okay.
No, I wouldn't, because it takes so long.
I just wanted to mention it because I think it's important that those animals, they need to be under anesthesia and a proper
Right.
place and so on, right?
Yeah, no, I appreciate
yeah.
that comment because it's true. There are some things we do standing, for sure. I personally have never had to take an eye out standing. I know a lot of vets do, and a lot of vets are comfortable with it, and I would really like to be a part of that one day to see how they do it, because I've never been trained in that way. It just seems a little bit like, ugh.
Come one day.
Yeah, and you do it, and you're good at it. A graft is a very different deal. grafts, they can't move at all. You need magnification for those. They are laying down for those surgeries. And it's true, the facility makes a difference. I'm not going to say that you can't put it on the floor of a barn somewhere. I've had to do it in a pinch. But I'll tell you, it's dirty. You've got an eye that's open. It's a problem. And so having it in a clean facility, preferably up high so you're not killing your back for 3 hours. Not that it takes forever, but an hour and a half. It's much better to be in a normal, good facility that can actually do medical therapy afterwards. Because they're kind of a big deal. They're easy, they're good, I love them, and they have a great prognosis afterwards. But you want to give it every chance to have a good prognosis as well. So yeah, so the surgery facility is really important as well. Hello.
Yes, in your experience and professional opinion, what are your thoughts on equestrian magazines such as Equus in terms of accuracy and usefulness?
Just topics in general? You mean
Well,
like
yeah.
if somebody had a topic they wanted to discuss?
Well, no, you discussed medical related articles. I just wanted to know what your experience has been.
Yeah, I don't have any issues with it personally. I haven't read anything that I go, oh my God, why would they ever suggest that? Because in my experience anyways, now I'm not talking about lamenesses or colic treatments or anything like that, because that's really out of my area. So some of that might be really just But as far as the eye goes, I think from the ones that I have read anyways, I have read a number of them, that they really do run it past somebody who knows what they're doing first before they just go and publish something. There's too much of a reputation of the magazine to be just randomly taking people's advice and saying, oh, okay, well, you've had this experience, you can publish it. I think it's too hard to do that. And they've got too much online for that. Because if they wrote a whole lot of really wrong stuff, I think people would be really taking issue with it and maybe not buying the magazine again.
Equine says vets usually write
Yeah.
those articles.
I think they do too, or they have people who are at least in the field and know and have consulted with somebody. So, yeah. So I don't actually think that they're bad. I find that they're usually a little bit not very specific. They're kind of very generalized topics more than anything else. So to get the really specific stuff, you want to be going to an actual journal, medical journal of some kind.
You can be a little bit disappointed with some of the topics that they show, even though they are technically written by veterinarians. But I think the problem with commercial magazines, you gotta remember who is funding them in reality.
That's another good point.
So, which is basically the ads that they are in the magazine. So.
Yeah, no, that's a very good point. It's true. Things are really driven, but I still think they can't be writing things that are overtly wrong either. So
No.
I don't know that I would be looking at this going, oh, I don't know if I trust that, because it's probably rooted in truth somewhere. They might have embellished a little bit, or perhaps it might not be the best treatments today, but at least you know if you're not getting horrible advice, you're not getting the wrong advice. Any questions on that side? You guys are really quiet.
No, you had the lights on over here.
It's what?
You had the lights on over here.
Oh, yeah, that's true. That's true.
All right, well, I'd like to thank Dr. Ford for a great presentation. So we'll take just a few minutes as we switch the computers around, and then Dr. Paton will give a short, brief kind of talk on the MRI that's coming in November. Just to give everybody kind of a brief description of what to expect and a little bit of the process.
Thanks, Eric. Is that going to work for everyone? So I'm not making a presentation tonight per se about MRIs. If you want to know about MRIs and degenerating protons, there's nuclear physicists out there. If I want a really good night's sleep, I read about that, and everything's good. But thinking driving over here tonight, it wasn't lost on me. I remember my father talking about his dad, my grandfather, arriving in British Columbia in the late 20s. And it wasn't till, as a 20-year-old, and it wasn't until about 20 years later that he got his own car and started driving around, and before he died, they put a man on the moon. And my point of this is, 35 years ago, I started in the Fraser Valley, and now having an MRI coming to our practice with 6 veterinarians and 6 employees, there's something in that analogy that's ringing true with me about how far things have moved and how quickly, if you will, because we didn't even know about MRIs, period, 35 years ago. And here we're now getting one with Fraser Valley. And we looked into this several years ago, and our practice, I would hope, will be known for a long, long time about providing what we know is valid and working. And we didn't jump into this, but we are now moving forward. We were actually given some credit because when we looked into this initially, and you'll see some pictures tonight, there's some very technical equipment, some dedicated rooms or buildings had to be built, specific electrical wiring. It was very complicated, very expensive, and we declined moving forward several years ago because we said, you know, there's just got to be a better way. And the company has given us credit. We're going to be the third one now, where this MRI unit is going to be modular. It's literally going to be like a container, if you will, taken off of a truck, plugged in, oversimplifying this, but we're going to have our MRI. And it's allowing us to, I think, in some ways do a better job, be able to do a more economical job, and give some flexibility. Like, who knows, someday there might be a subdivision on the road and we can move the MRI along. So, you know, what can it do for you? And there's some things we need to talk about a little bit, and there's some misconceptions about what MRIs are able to provide for us in the way of information. They can provide a tremendous amount of information. But what's important is we need to have a good workup to know as specifically as we can where the lameness is originating. You just can't walk your horse or a person into an MRI and run it across the whole body and say, oh, there's the problem. We've got to narrow it down. And of course, you can all appreciate if your shoulder is really sore and they can't figure it out for radiographs or ultrasound or other diagnostic modalities, you still know your shoulder's sore. That's where they're going to MRI. They're not starting here and going to here. We have to go through that same process with horses. So if your horse is lame, there'll be some diagnostic evaluation, starting with tooth tester, starting with nerve blocks, starting with going, aha, this is in the pastern area, this is strictly in the foot, it's in the fetlock. There'll be some radiographs taken. There's no point in doing an MRI to find a bone chip. But on the other hand, if the initial diagnostics, radiographs included, or if it's an area where we can accurately, to a degree, assess soft tissue with an ultrasound, those diagnostics are going to be done first. Having said that, and just talking about certain soft tissues, including tendons, where an MRI could be of an advantage, and I remember Dr. Snyder at WSU saying, not too many years ago, that ultrasound in his hands has become an antiquated diagnostic tool because, and his point was, the MRI can tell us so much more. Now, that isn't to say that if we ultrasound a tendon and find an obvious tear or a hole, that we have to get an MRI done. We have a diagnosis. But on the other hand, and I think of a case not too long ago, in fact, in August, where this horse went acutely lame. We, in a warm-up ring, the tendon sheath was swollen in this region here. We blocked it out, the horse went sound. The horse got better several days later, not 100%, but it was improving. We ultrasounded it, we couldn't see anything. We thought, well, we'll just rest this horse for an appropriate period of time. After about 4 weeks, it came back, not to work, but just light exercise, and very quickly went lame again. Not as lame as initially, but lame. We set that horse down for an MRI, and lo and behold, there was a linear tear in the deep flexor tendon within the tendon sheath. Those are not observable with an ultrasound, but we were able to find it and probably save that horse's athletic career because we defined, and I talk about that a little bit, an accurate, definitive diagnosis. And that is so important because a lot of times we're just guessing and playing the odds. And that's important because it affects the treatment and, of course, the prognosis, and that's important. I talk about cost effectiveness. I mean, yes, an MRI is going to cost in the $2,000 range, $1,900 or so with the standard. I'll talk a little bit more about that. But we had a case that came into our clinic, had been treated locally with $12,000 worth of diagnostics and treatment for a problem in the foot. It went down for an MRI, I'll show you the lesion later, to Seattle, and defined a tear in a tendon within the foot. Well, there's no way on earth that you can diagnose that. If it blocks out to the foot, normal diagnostics aren't finding it. You've got two choices. You've got to rest it and see, and there's nothing wrong with that. But on the other hand, the problem with resting and see is that I often say this, you wait till an animal's sound, and then you wait a bit longer. Well, how do we really know? Because it's very easy to see a swollen tendon in the cannon bone area. But if you've got that same tendon that carries all the way down and attaches in the foot and it's torn in the foot, the treatment, or certainly the rest, is similar. We're talking 9 months, 12 months, a whole rehabilitation process, even though it started to look better. Same as your big bone tendon, you can very clearly and easily see that. But you can't see it within a structure such as the foot, for example. So my point of cost effectiveness is you can spend an awful lot of money trying this and trying that and waiting. You don't wait long enough, your horse goes lame again. The next thing you know, you spent 12 months on board, you've spent all kinds of things. So it can be very useful from that perspective. Now I'm just showing you some of the other types of MRIs that are available. And there's nothing wrong with this MRI procedure, but they involve general anesthetics. And this is one that's down in the Seattle area. There was a mobile unit that went around for a period of time. You can appreciate the issues there. The horse had to be anesthetized within a clinic and then rolled up within this truck. Very good images are available, but you can appreciate there's some issues associated with that. This is another MRI. This is a similar one to what we're using. It's a hallmark, and it can be used for some of the upper limb findings. Ours will be excellent for anything from the knee down. It's particularly good for lower limb. And in certain instances, we'll be able to do hocks and in particular high suspensories. But there's some issues associated with that. The general anesthetic MRIs are needed in certain circumstances, but the majority of the problems are in the lower limbs. So why did we choose a standing MRI? Well, there's a number of reasons, cost being one in particular. To get an MRI done under general anesthetic down in the Seattle area, the client I was speaking of recently, it was $2,800. There was a $500 discount included in that for, I'm just not exactly sure why, but there was. So we're over $3,000. Plus there's the cost of transport, cottings, etc. The main reason we chose the standing MRI is because the Queen thought it was good enough. She got in touch with me and said, that's the one for you guys. But having said that, there is a long list of institutions and very well-established veterinary practices around Europe, in the United States. WCVM in Saskatoon has one, University of Davis has one, several of the universities in the eastern US have them, and the bottom line is that is the unit. I'm going to show you a short video clip now, Antonio, if you don't mind setting it up, which will just show you more graphically how this standing MRI works in horses. So this is a very famous veterinary practice in England, just out of London. I think the volume actually works on that, Antonio, but what he's talking about here is the need to remove any metal. The horse will be given a sedative. It's a big sedative. I really liked it when you used to go poop.
Well, it's loading up, so that's why we see it a little bit.
Okay. So the horse has been sedated. They're walking it into the stocks. They're placing the foot in the MRI field, if you will. This process takes between an hour and a half and 2 hours. It's not just like taking a radiograph or having an ultrasound exam done. Both limbs are done for comparison. That's important. And the reason it takes a while is that you have to be fastidious in getting good quality images. Because, as I'll show you a couple of examples in a minute, some of the lesions are extremely subtle. And if you have poor quality images, it's like poor quality radiographs, you're not going to be able to see clearly what the issue is. One of the things that's very important with the standing MRI is that the horse has to remain extremely still. The images are all digitized, and the technician makes sure that they're good quality, the veterinarian makes sure they're good quality. These images can then be forwarded to a radiologist if so required for second opinions. There's a very large number of images. What these are thin little slices. And it's like taking a loaf of bread, if you will, and taking one of the slices and turning it around and looking at it. So we go through these sequences of images. There's different phases, different types of images that can be created, and those are dependent a little bit on the type of study that you're doing. Is that still moving forward, or is there a way to kick it into gear, Antonio? The bottom line now, we've repeated, but you basically turn the horse around and back it in for the rear limbs. Basically, I think that's it, Antonio, or maybe we're going to let it go. But the bottom line is you just turn the horse around and back it in for the rear limbs. You can appreciate the size of that room and that building that they had to construct. I can only imagine the construction cost. Well, I know some of them that we looked into it before. I think that's fine. You can just, well, here we go. This is the back. And the horses tolerate this very well. That you can appreciate they have to stand very still while the unit here scans the area, if you will, or moves up the limb as you're required to look at images higher up.
So is it a probe that's just moving?
Well, again, it's sort of, if you will, a magnetic field in simplistic terms that goes around the limb. And there's some sensors in there that get into technology that is beyond me and would take a half an hour to give you the short version of how it works. But it basically has to do with the magnet aligning protons and various other things that if they're damaged, and I'll show you that in a minute, if you could pop up back to the original, oh, we're there, sorry, PowerPoint, same damn horse. But the image is then processed, if you will, and kind of put onto an image on a screen that we can look at. I'll just show you some of them now. And that's basically what they look at. But you've got to appreciate, those are virtually microscopically thin images. So that's why another reason it's very important to be as specific as you can as to where the source of the limb is generally coming from. You know, is it the foot versus higher up the limb? This pointer is right here, maybe. Okay. The long and the short of it is, you can see these are crowder ligaments. Those are ligaments that 2/3 of it is below the coronary band within the foot capsule itself, the hoof capsule itself. There's only 1/3 of it that is above. And these are very difficult to diagnose. Nothing generally shows up on radiographs. You could be speculative about it if one half the foot is blocked and the horse goes down, that maybe you have something that only involves one side of the foot. And you can see this ligament image here versus the more normal on this side here. You can see over here this white area is within the long pasturing bone. That's bone edema. And you don't think about it, but bones can become bruised, and they don't necessarily show up as a fracture or a roughening. This is within the foot, so it virtually can't be imaged by any other way. But if you, for whatever reason, have had severe trauma to that bone, it can take a long time to get better, but specifically, you don't know for sure what it is. We've got a flexor tendon down here. This is the one that I was talking about that's been injured, that had all kinds of money thrown at it, and all it needed was an MRI to tell us that this is the reality of this horse's foot, and rest is your main friend. I mean, there's lots of times there's other things that we can do, other sorts of modalities, but it gives us an idea as to what sort of both therapy and, most importantly, rest. This is very difficult to even see. There's a lesion right there that's very significant. It's very tiny, but very significant. And without the benefit of an MRI, you wouldn't be able to see it. You can see that dark area up here. Again, another type of trauma to that pasturing bone. So that's a very quick and somewhat superficial overview of the MRI. But we just thought it was important to let you know that the process is underway. We really have heard from you over the years that we need to have an MRI in the Fraser Valley. We need to have one in the Pacific Northwest, really. There are going to be certain circumstances where we are still going to recommend that your horse needs to go elsewhere for a general anesthetic, for an MRI of certain regions that aren't accessible by the standing. But the harsh reality is that the majority of lameness cases emanate in the lower limb. So in the majority of cases, lameness is in the horses. We are going to be able to be helpful with this new technology. As Dr. Martin alluded to, it's going to be early November. There's a bit of a process that's going to be installed in late October, early November. There's going to be a couple of weeks of certification, if you will. There's some training that's going to be involved, but we're hoping that by mid-November, early December, we're going to have this thing up and running. It is going to be something that I think that all the veterinarians in this area, and certainly the clients, are going to be able to benefit from. And thanks to you folks as well, it's been great for us to be able to come forth and do this. So there's a number of us here. If you have any technical questions, you might want to wait till afterwards. Maybe we can address them, but certainly any non-specific or generalities, let me know.
Very technical question.
Yes.
Are you on that horse taking the picture?
You know, I am on that horse, and I took that picture. I've gotten a little bit of grief, and if there was an interest, I would do it sometime. But I had a fabulous trip to Africa, and we did do a standing eye enucleation in less than ideal conditions, but they were more than adequate. That was one of my little shining badges I'll carry with me, is taking out a really bad eye in downtown Botswana. And we went for some nice horse rides as well. So, yeah. Any other questions, please? Yes?
So will this be the only standing MRI in the Northwest? Or?
Well, I would suspect so for some time, because in Washington, there are two MRIs that are both involved general anesthetic. One in Seattle, one that's good in Pullman, and that Pullman's 8 hours away. There is one in Central Oregon. There's a standing MRI. There's one in Saskatoon. There's none in Calgary, or at least Alberta area. So to answer your question, yes, it will be.
And why would that be?
It's damn expensive. No, I mean, really, everybody thinks, oh, we need an MRI. But in reality, when push comes to shove, oh, well, we'll just rest it and see what happens. And I get that. I mean, I understand it. And that's not an invalid treatment in a lot of circumstances. But on the other hand, there's often a valuable and sometimes I call it economical need to know. There is only the reality that probably one practice in the Pacific general catchment area of this area, you know, if everybody had an MRI, no one would have an MRI because none of us would be able to even come close to paying for it. In fact, the harsh reality, I don't mind sharing it, our practice will probably never make money off this MRI. We may be able to afford it by referrals that come for surgery after the MRI, or They didn't have standing MRIs until 10 years ago. And the software, oops, I don't know, I meant to shut that off, but I guess we're okay. The software associated with the hallmark MRI has dramatically changed over the years as well. Motion, compensators, et cetera, et cetera. So that's another reason that some of these previous organizations didn't go for them. But if you go to the website of these hallmark people, you know, boy, it's a pretty impressive list and growing of practices that are now going to. In fact, several of the universities have both, and the harsh reality is that they, I don't want to say rarely, that's an overstatement, but the standing is used for the majority of their MRI work, for obvious reasons.
Well, as a horse owner, I mean, if you know, having the choice, I would prefer to have a horse under just sedation rather than general anesthetic, if, you know, if at all possible.
Yeah, and not that you have to be overly concerned. I mean, if I needed a horse's upper limb MRI, I wouldn't be overly worried about sending it. But yeah, there's just added factors, and it's down there and not here, and you know, all that kind of stuff.
You know, during my tenure at the University of Guelph, we had same magnet as Pullman does have, and logistically is complex in terms of the amount of people you need, you know, anesthetizing a horse. You have to have tables and all the equipment that they are non-ferrogenic, which are very expensive as well. So that's from the general anesthetic point of view, but also those machines are incredibly expensive to maintain and to install. You know, I do remember that the budget for that machine was like $4 or $5 million plus, you know, $150,000 just on maintenance. So, you know, they're incredibly draining, but it's mostly used for small animals in reality, because with the standing magnet, most people will decide to go on the standing magnet. You get really good images, and you get diagnostic images without having to anesthetize the horse. So all of a sudden you're converting a process of two days, you know, by the time you bring the horse, get it ready, anesthetize it, then spend a night in the hospital, make sure everything is fine, in an outpatient procedure, you know. So it's like you bring your horse, he gets the MRI done, he goes home in the afternoon. So, you know, there's really it's a no-brainer in reality, you know. So.
Yeah, well, it's just that I've sort of had to consider that recently, and the thought of having to go through that process of, you know, having to truck them down and, you know, a few days in general anesthesia really put me off of, you know, going that route.
Well, I mean, you go to Europe. Europe is very standing magnet centric. So meaning that, you know, most people will go with a standing magnet. In North America, it was the opposite way. Now it's starting to change the tides, because people is realizing that the images that you get, they are diagnostics. The company's done a great job in getting, you know, better images and better software on how to process the images. So in reality, it's like you get diagnostic quality images, and that's the bottom line, without, you know, anesthetizing the horse. I mean, if the horse needs to be anesthetized, well, it has to be anesthetized. Anesthesia's come a long ways, and, you know, it's a reasonably safe procedure. But if you don't have to, why would you? You know.
Yeah, I didn't put the name up as Hallmark NARQ, and they have a list, and it's quite impressive to see the number that are in Britain and in Europe, South America, and just, you know, more and more over here. You bring up a good point. I mean, Poland led the way, but that was the technology in North America, and then newer technology is taking a little while to kind of catch on, if you will, but now it's dramatically becoming the way to go. I think you were the first to ask.
You mentioned you might be able to go higher up on the lake, so with this, or what we...
You can go up to, and it depends on the size of your horse as well. You can do hawks. It's not that the technology of the magnet can't do it. It's the problem with motion. If that horse just is this, you start to hurt him. If you're locked down like this with your lower limb, your horse will stand there forever. Or you have to at least start in the sequence over. Like, say, for example, you've done the foot, but you also want to include the pasture, and you've got the foot done, that's okay, but it loses the pasture. You've got to start over, and you've got to start your whole sequencing through again. So one of the downsides, if you will, is the potential of this horse just moving a little bit. But that doesn't mean we can't do it. Now, if it's a 17-hand warm blood and the hawk's up about here and it's this big, well, it's not that the technology of the magnet isn't good enough, it's just the technology of the unit and the horse in motion and things along those lines. But in a lot of instances, we can get some degree of, well, the image isn't the problem, it's just can we get it? The horse stands still enough or small enough, and it's not an issue.
So a stifle would be fine.
Stifles up, yeah. And even with the anesthetic, general anesthetic units, the stifle is still an issue that can, more or less can't be done, I would say. Is that
Yeah, the only place that is really reported doing stifles right now is Alamo Pintado, and they actually have to get it in 2 different images. So it's very, very challenging, and they are limited by the size of the horse as well. Not all horses can be, and we're still learning a lot about stifles MRIs. It's not a streamlined process by any means.
I think the way to think about it, you can now go and at a lot of local clinics get an MRI done of the lower limb, the human I'm talking about. If you want one done of your head or abdomen or pelvis, you've got to go to VGH where they've got this great big one, right? And we don't have the $5 million for the great big one. I'm not sure where we're going to get. No, but anyway. Bob, you had a question.
You know, technology is moving along at light speed these days. And can this machine of yours be adapted to utilize this new technology? Is it just software technology or is it diagnostic? Or?
Dr. Cruz might be able to better answer that. But
Sorry, what was the question?
Well, as technology moves forward, will our unit be able to adapt to that? And it comes back to, and we are, we've done our due diligence on this company, and by not jumping in 10 years ago, we were kind of going, gee whiz, the images are okay, but well now they're great, and that's because they have continued to develop the software needed. The magnet, if you will, is still the magnet, but the technology of getting the images from the magnet, and as I said, motion compensation and various other things, that's what's really improved. So I have no doubt that this company is going to have to keep pace, or they'll be displaced out of the marketplace by somebody else who comes along with a better idea.
Yeah, the only thing you won't be able to change the magnetic field in reality, because that's limited by the coils on the sides of the magnet. But everything else is post-processing of the image, which is related to software development in reality. So.
And that's where the change of opinion goes.
Yeah, huge. Yeah.
Well, thank you.
One of the questions I was asking earlier that I thought was worth bringing up is you guys also have to realize that when you get these done, it's not like us sitting out at the farm looking at 5 or 6 images or 20 images of your pre-purchase exam and giving you the answer. I promise you, we will be better than the Canadian healthcare system of getting you information fast. But it will not be instantaneously. These procedures take anywhere from 1.5 to 3 or 4 hours. Then they go to a board-certified radiologist. They look at hundreds of images. This isn't a series. You think you take a lot of x-rays at a pre-purchase exam of 30 images. These are hundreds of images. They compare side by side these images moving back and forth. They go over them ad nauseum, every structure of that foot. So it will be it'll be different, but it won't be as long as the healthcare system. But it will be a process where they have to do that, get back to us, then we look at the report and say, hey, here we go, this is what we're doing. So it's not something that you're going to be standing by your horse inside the building getting it done. It's a procedure where you bring your horse in, get them dropped off, and you pick them up later.
So who's going to read them? Where are you going to start?
Well, we have a couple of radiologists that are specialists, and no, they're not here, they're in the States. And it depends. I mean, there's certain things that will show up that, gee, I might not be able to figure it out. And there'll be some things that Dr. Cruz will be able to figure out, and there's some things that maybe a board-certified radiologist who specializes in the fine details of an MRI will be required to figure it out. But the neat thing is, boop, and it's in front of them. And they talk about 3-day turnaround. A point to be made is there's no such thing as an emergency MRI in a horse. It's not like we're wondering what's going on in the abdomen, we're going to run it in and out like a person. But it's a defined lameness, it's a defined workup. We know that there's no abnormalities visible within that foot by any other means but this. So then you move forward to this.
You need a test subject for your training?
Yeah, well, thank you. I mean, I don't mean to cut anybody off. We're going to be here. We prided ourselves, and we really appreciate your attendance of trying to be done by 9 or so that you can get home and not make it late tonight. But don't hesitate to ask. We're going to be here for a minute. If you have any other questions, phone up. But we just wanted to give you a very brief introduction to and update as to what we're doing. So thank you very much.